what can be done is we can tend to, if it's in the case of like a vocal cord weakness where someone is having swallowing issues because the vocal cord is not moving, we can tend to augment or enlarge or thicken the size of the vocal cord to improve both swallowing as well as voice function. If it's something that's going on along the track on the way down, then we can also help open areas up in the throat to allow things to pass down more easily. Now, that's the surgical perspective of it.
Hello, this is Anthony Effinger. I'm the host of the Think Neuro podcast at Pacific Neuroscience Institute. And today I am speaking with Omid Medizadeh. He is an otolaryngologist at PNI. Welcome.
Thank you. Thanks for having me today.
So tell us a little bit about your background and your education to start.
Yeah, so as you mentioned, I'm an otolaryngologist. I did my residency training at I did my medical school at UC Davis in Sacramento. And while I was there, I did a research fellowship in voice and swallowing disorders. Afterwards, I went to NYU for my residency in otolaryngology, ENT, head and neck surgery. A lot of names for that. I decided to do another 1 year fellowship, this time a clinical fellowship in what we call laryngology.
Now define otolaryngology for us.
So otolaryngology, oto ear, laryngology, throat. In Europe, they call it otorhinolaryngology, which is ear, nose, and throat. So it's just the medical as well as surgical treatment of head and neck conditions, excluding the brain and the eyes.
Okay, and these things all go together because they're linked in some way.
Yeah, I mean, we think of ENT otolaryngology as the medicine of the cranial nerves. So, just again, outside of vision, but the ears, the taste, smell, voice, listening, things like that, hearing. So essentially those cranial nerves.
So it's the nerves that unite all these things.
Essentially, yes.
Got you.
Yes.
How did you get interested in this?
I found it fascinating from a perceptual standpoint. I felt, again, it's the study of cranial nerves. It's how we perceive the world. It's how we interact with the world via smell, taste, speech, voice, audio listening, and just how it's essentially our phenomenology of what we express.
Mm.
And it's quite remarkable and similarly to neurosurgery or neurology, where the smallest aberration in any of these pathways can cause, unfortunately, severe disabilities and changes in quality of life. So, I just felt the science behind that was quite interesting.
What percentage of your time are you spending in surgery versus the clinic?
Yeah, it varies week to week. In general, we like to have approximately, I would say 30 to 50% time in the OR. Generally, 50% is a nice mixture between the operating room, being in surgery, and seeing patients in clinic.
Okay, and when you're in surgery, what sort of things are you doing?
I'm generally doing microsurgery, so surgery under the microscope on the vocal cords. So basically, essentially, any type of low grade cancer or early stage cancer, or lesions or changes on the vocal cords, which may cause changes in voice.
Interesting. And you use a microscope for that?
Yeah, yes, you do. So typically it's done via, most of these procedures are done through the mouth via
Okay.
a small hollow tube. And then we use these very small instruments on a long forceps to essentially pass that through the tube and have the microscope as our line of sight to work on the vocal cords. Outside of that, a lot of my practice is also swallowing or changes in swallowing dysfunction. So a lot of those procedures are performed endoscopically via flexible cameras, flexible scopes. And then if we do decide that we need something more invasive, depending on the pathology, we're doing open surgery in the neck to get down to the voice box or the swallowing muscles specifically.
How large are the tumors that you're removing on the voice box?
Generally, I would say on the order of less than 5 millimeters,
So
so less
tiny.
than half a centimeter.
Wow. Okay. And
Yeah.
what causes those?
So the tumors generally we suspect smoking history is
Yeah.
a common one, or at least tobacco exposure. Most of the pathologies, most of the diseases that are benign on the vocal cords are generally on the order of 1 to 2 millimeters in size. So if you hear someone with a really raspy voice, many times that's actually being caused by something that's thinner than your fingernail.
Hmm.
And those are generally due to voice, what we call voice overuse, or in the past, what we call voice abuse. So
Hmm.
someone who's just, talking a lot or misusing their musculature in the voice box, overstraining, creating a lot of friction that tends to lead to these different types of vocal cord issues.
Is that like sort of scar tissue then?
Sometimes it's scar tissue. Usually it's something like a polyp or a
Yeah.
cyst, or people know the term nodules quite.
Hmm.
That's quite familiar to people, the term nodules. But that's a very, in our world, it has a specific term, but it's understood to kind of encompass most of those issues on the vocal cords that
Yeah.
people tend to develop.
My mom had that. She was treated for that a couple times during her life. And you
Yeah,
could tell after she was treated, her voice would change. It
yeah,
was way
yeah.
less gravelly. There was not that interference.
Yeah, so definitely, it's amazing how the smallest of structures can make such a big change.
Mm.
And then, unfortunately, sometimes people also develop vocal cord paralysis, so the vocal cord stops moving. The most common cause of that is post-surgical, so generally chest surgery, heart surgery,
Hmm.
like a carotid, like excuse me, not carotid, but like a coronary artery bypass surgery, CABG, thyroid surgery, as the nerves that control the vocal cords are running directly behind the thyroid gland in the lower neck. And the reason people develop vocal cord paralysis from chest surgery is because the nerve that controls the vocal cord, the recurrent laryngeal nerve, actually goes down into the chest. So
Oh,
it goes from the skull base down through the neck, down into the chest, and then back up into the neck to ultimately go into the voice box.
I see. And that something is something goes wrong there. And
Yeah.
that's the
Yeah.
okay.
So, yeah. So generally anything that goes wrong along the entire course can
Yeah.
cause the vocal cord to become paralyzed, including strokes and other neurologic conditions.
Yeah. Do you see like singers?
I do. Yes.
Yeah.
Singers as well.
Yeah, you must. In LA, there's probably plenty of those.
Yes, yeah, it's a very interesting aspect of our field. It's a lot of choosing when to intervene and when to play it conservatively, as their voice is their livelihood, and we want to ensure that we're only helping and never making anything worse.
No, absolutely. Yeah. So I gather you see a number of people who are getting older and you're treating changes that happen with voice and swallowing. Is that right?
Yes, yes, and unfortunately, similar to a lot of other bodily processes, the voice does change, swallowing function does change as we get older.
What happens?
It's generally, we believe in terms of swallowing, we think from what I've been able to collect through a lot of the research that I've done, people consider swallowing issues as we get older to be a normal process of aging. And similar to muscle weakness, we have changes in walking, our neurologic structures weaken, our muscles atrophy, the muscles get thinner, so they're just not as strong as they used to be. It tends to be similar in the throat, as well as the esophagus. However, fortunately, there are things that we can do to intervene. So, one of my goals today was at least to discuss how, although these processes can be considered quote unquote normal in aging, it doesn't have to be dismissed as something that we have to live with,
Hmm.
and especially something that will just unfortunately affect the quality of our life. So that's really something that I was hoping to discuss today.
Yeah, yeah. So what can be done?
Yeah, so for example, some of the things that happen are generally in the setting of neurologic conditions. So, with swallowing specifically, people can develop Parkinson's disease. They can develop any number of primary neurologic issues. Stroke is a predominant one that tends to cause profound issues with both voice and swallowing. So, what can be done is we can tend to, if it's in the case of like a vocal cord weakness where someone is having swallowing issues because the vocal cord is not moving. We can tend to augment or enlarging or thicken the size of the vocal cord to improve both swallowing as well as voice function. If it's something that's going on along the track on the way down, then we can also help open areas up in the throat to allow things to pass down more easily. Now, that's the surgical perspective of it.
Wait,
One of our main
let's hang on. I want to stop there for 1 second and ask you, how do you augment those muscles?
So, for example, if it's a vocal cord, we can inject it with a filler.
Huh.
So traditional to similar to facial fillers, we have fillers for the vocal cords,
Wait,
and
so we're like lip plumping our vocal
essentially,
cords?
yeah. And some of the earlier injectables were, and actually some of the injectables that we use quite commonly now are facial fillers, like Juvederm.
So this is plastic surgery for the vocal cords, is
That's
that?
exactly what it is. That's exactly what it is. Yes.
And what does that do?
It brings the vocal cords closer together.
Ah,
So yeah, we have two vocal cords. They move in and they move out, and they need to come in and contact each other successfully to have a strong voice and a strong swallow function.
hmm.
And
Okay.
by injecting them, we move them closer together. Um,
Oh,
yeah, because what we worry about in people who have swallowing issues is aspiration,
yeah.
essentially food going down the wrong way, increasing the risk of pneumonia, hospitalizations, weight loss, all of these factors. So we want
Now
to
is that's because you need the vocal cords to close off when you're swallowing, so to prevent food from going into your airway. Is that
That's
right?
right. That's
Okay.
right. That's
Huge,
actually
huge
the
function.
primary function of the vocal cords is to protect our lungs.
That right. I think people forget that or don't know
Yes.
that.
Yeah. Yeah. And
Okay.
it's one of the last it's one of the last reflexes that goes away.
Oh,
Swallowing and the vocal cord spasm are the one of the last reflexes that we use, unfortunately, in
hmm.
brain death to assess whether someone has a functional capacity in that sense.
Yeah, I remember, yeah, as my mother got older, that, when you're very old, that's what happens. And then I had a friend who had Parkinson's, and I think that's ultimately what got him
Yeah,
was
yeah,
that.
yeah, and that unfortunately is one of the most common things that happens to it's a fairly common experience.
Mm.
It's a fairly common experience in terms of end of life care, how to respect someone's dignity in the sense that they want to eat and they want to drink, but it
Mm.
also increases their risk of aspiration and pneumonia. So it's really a fine balance between those two factors. And a lot of my work is in that area, is advocating for those patients
Mm.
who ultimately they do understand that they are placing themselves at risk of pneumonia, but ultimately it's what they want to do. So we just try to support those people as best as we could.
So the reason aspiration causes pneumonia is because you get some foreign substance in your lungs and that causes infection. Is that right? Or how?
Yes, yes, definitely.
Okay. You really don't want anything in your lungs except air.
Yeah, air and yes, and generally we're good. Younger, healthy people or anybody with a fairly strong cough reflex is able to protect their lungs. But it's that aspect as well that our cough gets weaker and our
Hmm.
lungs get weaker as we get sicker. That is another aspect of why we develop pneumonia. Essentially, the bacteria that goes down from our mouth into our
Okay, right. The
lungs.
bacteria, right. Okay. So had I stopped you at the augmentation of the vocal cords, where were you going from there?
Well, essentially, it's remarkable. There are over 48 muscles involved in swallowing,
I'm
and
sorry, you said 40?
40 to 50 muscles.
40 to 50. Okay.
Yeah, including anywhere from the tongue to the mouth to the throat to the vocal cords. These are all in some beautiful concert of sequence that allow food to successfully go from our lips down into our food pipe or our esophagus. And anything that could
Mm.
affect that timing, that strength, can cause us to aspirate or choke or cough while we're trying to swallow. So the vocal cords are just one aspect. Fortunately, they're fairly straightforward and directly accessible part of swallowing, which is why we like to focus on those at times.
Accessible meaning you can get to them through the throat.
Yeah, we could get through
Yeah.
them through the mouth. We could get through them through the skin of our
Mm.
neck, through our neck. So some of these fillers that we inject into the vocal cords, we actually do awake, just using topical anesthesia.
Wow. That's fascinating. Um, okay, so that's how you recondition them that way. What else can be done as someone ages and these things begin to atrophy?
Yeah, so we commonly utilize voice therapy, swallowing therapy. I would say that our speech and swallow colleagues are the speech language pathology world, which people are generally SLPs, which people generally, in my experience, are more familiar with like pediatrics and children speech therapy. That's the role that I think most people tend to encounter, but a lot of speech language pathologists also focus on adult swallowing and adult voice. So there is a whole world of that type of therapy that we can offer patients to help improve swallowing strength, swallowing function, and voice.
It's funny again to mention my mom is in her when she was in assisted living, they had a whole staff.
Right.
And as she,
Right.
turned 96 and, that began having a couple of strokes, that's exactly what they did. She saw
Yeah.
the speech therapist. They did all the exercises. They taught her how to hold her chin
Mhm.
and these sorts of
Exactly.
things, right?
Yeah, exactly. Like a lot
Um,
of these maneuvers and head
maneuvers.
turns and chin. Yeah, and I think it's such a, unfortunately, I think it's such a common experience amongst us. I think everyone has had a parent or a grandparent who has had to go through this.
Yeah.
Um, and yeah, it's again, it's such a common experience of life.
Yeah. Is there anything that is there anything you can do when you're younger that to stay on top of this, to take care of these muscles and
Yeah,
this system?
that's a great question. Use it or lose it,
Hmm.
essentially. So, we find that as we tend to have some smaller, more mild issues, people tend to shy away from having them treated.
Hmm.
So I would say early intervention is very important. So at the start of any swallowing symptoms, having an evaluation would be very, very helpful. And again, just being social, speaking. We found that singing can actually be protective for vocal cord atrophy or thinning of the vocal cords as we get older. But that's from a vocal cord standpoint is utilization, but of course not over utilization where we're shouting and we're straining and we're
Hmm.
screaming, because that's when we start having those other vocal cord issues.
Yeah. Okay, so that's sort of like you said, use it or lose it. That's sort of like going to the gym for your voice, right? I mean, if you
Yes.
are using your voice and singing and yeah, okay, that's interesting.
Yeah. So I love it when I hear
Um,
people singing in the shower, singing in the car. Uh,
yeah.
that's always nice to hear.
Yeah, 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 yeah. Um, is there anybody who's sort of more predisposed to encountering this, or is this just everybody as we get older?
No, that kind of brings me back to the original why, are these processes normal, specifically with swallowing? Is it normal to choke on food as you get older?
Yeah.
Uh, there's so many factors that, if addressed earlier, can potentially minimize your risks in the future. For example, acid reflux is one of them. And acid reflux being such a common condition that at least 30 to 40% of us experience,
Mm,
over time, acid reflux can cause changes in the way the esophagus or the food pipe pushes food down.
really?
So, oh, yes. I mean, I've seen so many swallow studies, essentially X-ray swallow studies of people drinking contrast, where rather than food moving flawlessly from the top of the throat to the bottom of the stomach, to the top of the stomach, excuse me, it just stays in the esophagus. And people are having discomfort. They feel food getting stuck in their chest. They've had to transition to nearly a liquid diet because they can't tolerate solid foods anymore. So I think acid reflux is one of those places that if we intervened on and controlled earlier, we may have better outcomes down the line.
Now, is that because the reflux the stomach is irritated or um right, and it's just not moving food. Why does it back up, I guess, is my question.
There's a lot of factors. Yeah, one is the stomach doesn't allow food to pass through successfully, so food backs up, acidic material backs up. Diet is a major consideration. So foods that tend to cause acid reflux, habits that tend to cause acid reflux, acidic foods, tobacco, alcohol,
Hmm.
eating late at night, going to
Hmm.
bed, allowing food to reflux up, and even acidic foods, like I think I meant, but like citrus and tomatoes tend to cause acid reflux. And then even obesity, having a little bit of extra weight in the abdominal area can push on the stomach and loosen the valve at the top of the stomach and allow more non-physiologic or abnormal acid reflux. And then acid reflux even runs in families.
Yeah.
Some families just tend to have more acid reflux. And then there's structural issues like hiatal hernias, which is a portion of the stomach not being regulated by its normal sphincter. So there's essentially some stomach that's coming through into the chest, and that's just freely excreting acid into the esophagus. And
Is that a problem with your pyloric valve? Is that no,
above that, your lower
above
esophageal
that?
sphincter. Yeah, it's called the lower esophageal sphincter. So it's essentially the level of the diaphragm.
Oh, wow.
So the diaphragm is a major muscle that keeps the
Yeah.
stomach down in the abdomen and keeps it out of the chest. But loosening of that sphincter muscle around the diaphragm can cause it to come up and slide
Okay.
up. Yeah.
So watch your diet. Um, don't eat a lot of tons of fatty food. Don't eat late at night. For sure, don't smoke,
Yeah,
right?
what's new with all these recommendations?
Get exercise,
Yeah, good
get a lot
exercise.
of exercise.
Yeah, yeah, and even exercise has been shown to correlate with improved swallow function.
I totally believe that.
Yeah.
Have you seen, have you seen it? I guess I don't know what the stats are on smoking. I think probably it's still going down, but I still feel like I see a lot of people smoking depending where I am. But are you seeing, any sign that maybe these sorts of problems are smoking related problems are becoming more rare or no?
I would say since smoking is only but one cause of these things,
Hmm.
from a cancer standpoint, yes.
Okay.
So, like for like vocal cord cancer, oral cancer, certain types of esophageal cancer. So those we have seen go down because of less smoking. But in fact, acid reflux is a risk factor for esophageal cancer.
I've read that. Yeah.
Right. Yeah.
So yes, that's a big risk. What about alcohol?
Alcohol as well.
Yeah.
Alcohol, yeah, tobacco, alcohol.
So, there's I think the Canadian Health Service basically says there's no amount of alcohol that's safe now.
Yeah, I saw that recently. That's
Yeah,
interesting.
which is a bummer.
Yeah. Yeah.
But I mean, I imagine it's like anything, everything in moderation.
I think people need to make the choices that are best for them, depending
Yeah.
on the risk factors that they have, based off of their family history. And I think it's always a conversation. And I think we're gonna have an evolution in
Mm,
the data and the science. Not that I'm advocating at all for alcohol use, but
of course.
I think these are all very personal choices, again, based
Sure.
off of the factors around them. Even a history of addiction. I know that's beyond our conversation, outside the scope of our conversation, but a family history of dependency as well, and how those factors play a role in their lives.
Yeah. When does this, when do you see the really severe surgical cases? What are the toughest things you see?
Yeah, I would say from a swallow standpoint, the most difficult cases I see are people who unfortunately have a feeding tube in their stomach, and they want to try to have that feeding tube removed and try to start
Mm,
eating by mouth. And usually those are people who have had some type of neurologic trauma, whether it was a tumor in the brain,
yeah.
or some type of stroke generally, but generally deficiencies in the higher nerves, like specifically the nerves in the brain. These people are aspirating on their own saliva. So
Yeah.
they're choking on their own saliva. and they're even developing pneumonia when they're not eating. So I have patients who, they're isolated. They can't go out to restaurants and they can't sit down for a meal with their family
Mm,
because they're not eating. And I think
yeah.
that's one of the biggest social factors. People just want to be with people. They just want to enjoy a meal. And so those are the most, I guess, heroic or
Mm,
extreme, most invasive surgeries that we're doing from a swallow standpoint, to try to facilitate some type of food by mouth.
yeah. Yeah. Well, then, well, two things. One, if you're talking about brain injuries, is is there any way to exploit the brain's plasticity to get that back, like you do would with like with other things with stroke, like voice, like speaking and so forth?
That's a great question. Early intervention, yes. Just like stroke, physical therapy, stroke therapy
Yeah.
is physical therapy, swallow therapy, voice therapy within the first 3 months of the stroke is crucial to try to help improve outcomes down the line. But unfortunately, when people are undergoing such a severe trauma, we're not really focusing on that. We're just focusing on, getting them healthier again and utilizing the larger muscles. And a lot of these people, unfortunately, are condemned to a feeding tube very early on. And they so essentially they have their stroke. They're having significant swallowing issues, and we place a feeding tube in their stomach. And then the swallow therapy can fall by the wayside. But I think getting those people into early and aggressive swallow therapy can be very, very helpful.
Okay, but you're saying that it's almost like at that period, the doctors almost have bigger fish to fry.
They have bigger fish to fry, and
Yeah.
there's many times there's not, depending on the hospital that you're in, there's not a ENT or a laryngologist who can do a vocal cord injection in the bedroom,
Mm.
at the bedside. So and I could count the number of times that I can't count the number of times that I've seen a vocal cord paralysis be the primary issue with someone needing a feeding tube. We do the vocal cord injection, and the next day they start eating by mouth. So
What is the vocal cord injection? Is
that's the filler. That's the
that's the
filler.
filler?
Yeah. So
So
ultimately, we
the
replace the filler by injecting the vocal cord with it
that's the filler doing that quickly.
that quickly, right? Of course it's there's many factors involved,
Sure.
but I have seen night and day. I've have seen people only using a feeding tube. The next day, we inject their vocal cord. Their vocal cords can close now. We get them a swallow study the next day, and they start eating by mouth.
Are you kidding me?
That's, that's the
That's
biggest
amazing.
win. That's the biggest win for us.
How long? How now? Shouldn't be surprised that this is new to me, but how long has this been a technique?
Decades,
Oh, it has really.
decades. Yes, yes.
We figured this out a long time ago.
Yeah. We figured this out a lot. In the past, we actually used to use Teflon. But we've stopped using that. There's a lot of issues associated with Teflon. We're constantly trying to find the newest, longest lasting, most pliable injectable material to allow someone to get their voice back as well as their swallow function back. But ultimately, if the vocal cord doesn't recover, we do an open surgery called a thyroplasty to put a permanent implant into the
Mm.
vocal cord to push it over.
What's the gold standard now?
So, in terms of doing a bedside injection, where we don't have to take a patient to the operating room, where many of us are injecting hyaluronic acid, which there are many different types of hyaluronic acid, but Juvederm is one of those.
Rejuvaderm.
Not that I have any financial
No, no, understood,
incentive,
understood.
but yeah. So Juvederm. So there's different types of hyaluronic acid. They can last 6 months, 9 months.
Huh.
Um, and there is one company right now that is working on. It's in pre-trials. Essentially, some voice centers around the country are using silk beads. So micro silk,
Like silk from
yeah,
spiders,
silk from silkworms, I guess.
silkworms. Right,
Yeah,
sorry,
but
silkworms. Yeah.
microscopic silk beads because we found that we already use silk in the body. When we tie off
Yeah.
to tie off arteries, we're using silk. So silk in its own right is also very inert. So this is an injectable form of silk beads in order to push that vocal cord over and allow it to start, allow someone to start speaking or voicing or swallowing again.
That is fascinating. So give me an idea of how much material you're injecting
Oh, yeah.
into.
We're usually injecting on the order of fractions of a milliliter. So generally, a quarter of a milliliter, half a
So
milliliter,
tiny, tiny amounts.
tiny amounts. Yeah, these spaces are millimeters in size. We're talking about 2, 3, 4 millimeter space between the vocal cords that we need to close off so people have improved voice and improved swallowing.
It almost sounds like you're like tightening the what do you call it? A drum cover, the top of a drum. Like
Mhm.
you're kind of tightening that up, or you're tuning something in a way.
Yeah, we're increasing pressure in the throat. We're closing off places like the lungs. So
Yeah.
essentially, things go down into the swallow tube and not into our airway or our voice box or our trachea, and ultimately down into our lungs.
So
Um,
if you looked at a healthy vocal cord, you know, the muscles, what do they look like? Pink and healthy and
yeah, white, pink, straight lines,
okay.
close completely, open completely. When we breathe in, they open. When we speak and swallow, they close.
And then as we get older, do they look just more
They get
beat up?
thinner. They get
Thinner,
yeah,
thinner.
they get thinner. They get and our all our muscles get thinner.
Yeah.
So we have muscles in the vocal cords, and then the matrix outside of the muscle also gets thinner and stiffens. So the vocal cords just don't come together that well anymore. So people's voice gets weaker,
Mm.
softer, and I've been quite impressed at some of my patients in their 80s who are and 90s who are still working. And these are people who have been working in very high influential areas. And the way they describe their symptom is I have lost my authority,
Mm.
or I have lost the emphasis in
Mm.
my voice. So they're no longer able to get their views across, or so we do these procedures and we revitalize their voice.
Well, and that's got to pay benefits in terms of if you have lost that ability, you've lost that authority, that's going to lead to more social isolation, right? I
Very much
mean,
so.
if you don't want to talk, you're like right, and
Yeah,
then that leads to cognitive decline, right?
it does. Socialization, people
Yeah,
stop talking to their friends because they don't want people to think that they're sick or
yeah,
they quote unquote sound old. So people just exactly they stop socializing, and then that ultimately leads to
yeah.
changes in cognitive function, and things tend just like our hearing, right? We stop hearing, our brain centers start to atrophy. So it's quite remarkable how I mean humans we're meant to be exposed to constant stimulus. That's kind of our brain is this constantly plastic structure
Mm.
that learns and adapts. And when we stop stimulating our brain, things start to become affected.
Yeah. No, that and people I think people they think about that when you talk about hearing. I know, like, you're going to be isolated, but you don't necessarily think about being isolated because your voice is changed,
Right.
right? But
Right.
absolutely happens.
Your voice, or you no longer you don't want to sit with your family for a meal.
Yeah. One last thing, P&I really focuses on you have a lot of otolaryngologists, or you have a number of them. It's become a huge practice area for P&I, right?
Mm-hmm.
Did
Mm-hmm.
how did that evolve?
Yeah, I initially started with our director, the ENT director, Chester Griffiths, and they had a vision about integrating ENT with neuro-ophthalmology and neurosurgery, and then it just trickled down from there, where we have the opportunity to specialize in all these amazing areas of ENT, and since they are the study of cranial nerves, we have so much overlap with our ophthalmology colleagues and our neurosurgery and neurology colleagues.
Yep, that's it. I mean, that's it, right?
Mm-hmm.
Yeah. And
Yeah,
skull base.
the
Yeah.
skull-based surgeons, the
Yeah.
neurosurgeons. I mean, these are. again, it's wonderful that having a close relationship with our neurosurgery colleagues and neurology colleagues, I could get called and say, we have this patient who just had neurosurgery and they lost their voice. Oh, or the swallow therapist saying that they're high risk for aspiration. Can you come see if there's anything you can do in the hospital to try to avoid that?
Yeah, totally. No, that's, I mean, that's the beauty of it, right? I mean, yeah, one stop and away, right?
Yeah, that collaboration. It's great.
Well, this is terrific. I so appreciate you taking time. I hope you'll come back and we'll find something else to talk about for sure.
It's my pleasure. Thanks for
There's a
holding
lot
me.
of it. All right. Thank you again, Dr. Medizadeh. We really appreciate it.
Thanks again.